Hi, my name is Shane Kuo. I'm a second-year resident at the University of Miami program at Holy Cross Hospital in Fort Lauderdale, Florida. Today I'm going to talk about my case report, a patient with functional bowel disease misdiagnosed as carcinoid syndrome, written by me and Dr. Wissam Zacko. To begin, carcinoid syndrome is a well-differentiated neuroendocrine tumor that arises from the enterochromaffin cells. NETs produce serotonin, which is metabolized to the inactive 5-hydroxyindoacetic acid by the liver and the lungs. Carcinoid syndrome is caused by the secretion of serotonin into the systemic circulation and is usually caused by a metastatic NET that originates from the mid-gut. Clinical features of carcinoid syndrome include episodic flushing, diarrhea, and in some cases right-sided valvular heart disease. The primary screening method for carcinoid syndrome is 24-hour urinary 5-HIAA, which has a 90% sensitivity and specificity in diagnosing carcinoid syndrome. Our case is a 29-year-old female who presented to our clinic with abdominal pain, bloating, diarrhea, and weight loss associated with postprandial facial flushing. She reports around 9 pounds of weight loss. Her medications at this time included dextroamphetamine and furmazenib. Based on her symptoms, a urinary 5-HIAA was ordered and was elevated at 148 mgs. Carcinoid syndrome was suspected based upon her symptoms and elevated 5-HIAA, and thus imaging studies were ordered to identify primary or metastatic disease. CT abdomen and pelvis was unremarkable and showed no abdominal mass or adenopathy. The gadolinium net spot scan was ordered and revealed no trace or avid malignancy. Upper endoscopy and colonoscopy were also negative at this time. Thus, carcinoid syndrome was less likely given the negative imaging and colonoscopy, despite the elevated urinary 5-HIAA. At this time, additional etiologies for the elevated lab values were being considered. The patient was asked to discontinue her dextroamphetamine and recheck her urinary 5-HIAA. However, initially the patient expressed difficulty in stopping the dextroamphetamine for urine collection, but due to the negative evaluation for NET, she finally agreed to hold it for 3 days. After 3 days, her repeat urinary 5-HIAA was down to 10.4, a remarkable downtrend from 148. Thus, her symptoms were believed to be secondary to a functional bowel disease, and the elevated urinary 5-HIAA was a result of her dextroamphetamine use. Her symptoms improved with mirtazapine and dicyclomine, and she regained the weight. This is a unique case with a misleading, elevated urinary 5-HIAA. While mildly elevated levels of this lab can be seen in tryptophan-rich foods and certain drugs like amphetamines, marked elevation, like in our case, is much more specific and usually only seen in carcinoid syndrome. Our patient had symptoms suspicious of carcinoid syndrome and a urinary 5-HIAA of 148, which is 25 times the limit of normal. However, there was no evidence for NET on the extensive workup, and the levels rapidly decreased when stopping the medication. To our knowledge, this is one of the highest falsely positive urinary 5-HIAA reported. This case underscores the importance of a complete drug history, including the over-the-counter medications, and that when the urinary 5-HIAA is elevated, the test should be repeated, and all potential interfering medications should be discontinued. Although this may be difficult with certain medications that are addictive, like in our case. Thank you and have a wonderful day.